Okay, let's talk about hypersensitivity reactions. We can refer to page 110 in the first aid book. Before diving into each hypersensitivity type, let's take the big picture. We all know that there are 4 hypersensitivity types. Hypersensitivity is basically an immune system overreaction that causes damage. So the whole time we will keep asking, why does the body do this and why does the patient look like this? Okay, for type 1 hypersensitivity reaction, it is an anaphylactic and atopic reaction, and it is immediate allergy and anaphylaxis mediated by immunoglobulin E, IgE, and mast cells. So for type 1, it's anaphylactic, atopic, and it is immediate and mediated by 2 main things: immunoglobulin E, IgE, and mast cells. For the type 2 hypersensitivity reaction, it's antibody mediated, cytotoxic, and usually mediated by immunoglobulin G, IgG, or IgM, directed against cells or tissues. Type 1 is anaphylactic and atopic. Type 2 is antibody mediated. Type 3 is immune complex mediated, where antibody antigen complexes deposit in tissues and it triggers inflammation. That is type 3. Type 4 is cell mediated, and it is delayed, and it is cell mediated. What cells? T cells, driven by T cells. No antibodies involved in type 4 reaction. Okay, so type 1, type 2, and type 3 are antibody mediated. Type 4 is cell mediated. Now let's zoom in on type 1 hypersensitivity reaction. Okay, let's talk about type 1 hypersensitivity reaction. We often remember it as first and fast. First because it's type 1. Fast because symptoms can happen in minutes. And it is anaphylactic and atopic. Anaphylactic means it's systemic body-wide reactions and it's very dangerous. Atopic is like allergy prone and usually localized to like nose, lung, skin, etc. The important part is that type 1 hypersensitivity reaction has 2 phases. So the 2 phases are immediate phase, which happens within minutes, and late phase, which happens in hours. However, before those phases can happen, there is an important setup step. The setup step is called sensitization step. This is why preformed IgE exists. So for an immediate reaction to occur, the person must already have allergen-specific IgE sitting on the mast cells. Why does this happen? Because on a prior exposure, the immune system mistakenly treats a harmless antigen like pollen, peanuts, or bee venom as dangerous and leans into a type 2 helper cell response. So here's the flow. First exposure to antigen, often no dramatic immediate symptoms yet. The immune system activates T helper 2 cells, and T helper 2 cytokines drive the allergic pattern. So remember the number of the cytokines. Interleukin 4 and interleukin 13 push B cells to class switch to IgE. Interleukin 4 and interleukin 13, IL-4 and IL-13 push B cells to class switch to IgE. And then IL-5 recruits and activates the eosinophils. Then the produced IgE binds to high affinity Fc receptors on mast cells. The Fc receptor on mast cells for IgE, often called Fc epsilon receptor. So why does IgE bind mast cells and just sit there? Because mast cells become pre-sensitized. Think of IgE as the sensor and the mast cell as the loaded device. Once IgE is attached, the mast cell is primed for the next exposure. That's why we call preformed IgE on pre-sensitized mast cells. Preformed IgE on pre-sensitized mast cells. Okay, so let's go to phase 1, which is the immediate phase happening in minutes. This is the classic fast allergic reaction. So the mechanism goes like this. Antigen cross-links the preformed IgE on pre-sensitized mast cells. And then there is immediate degranulation of the mast cells. There will be release of histamine, which is a vasoactive amine, tryptase, which is a marker of mast cells activation, and leukotrienes. Why does this antigen cross-linking matter? So one allergen binding one IgE is not enough to fully activate the mast cells. So the cross-linking means that the antigen bridges multiple IgE molecules, which is the confirmed threat signal to trigger activation. Why it's so fast? Because the mast cell is already coated with IgE and contains pre-packed granules. So once cross-linking happens, you get immediate degranulation within minutes. Okay, what kind of things get released from mast cells? So the first is histamine. Histamine acts on blood vessels and smooth muscle, causing vasodilatation, increased vascular permeability, and then the fluid will leak out, causing edema, urticaria or hives, and angioedema. And in severe cases, there can be hypotension and shock. And it also causes vasoconstriction, leading to wheezing, shortness of breath, and also cause increased mucus secretion, causing congestion, runny nose, and cough, etc. And there is tryptase. Tryptase is a marker of mast cell activation. So serum tryptase supports mast cell activation. So why we don't just test histamine? Because histamine rises and falls quickly, and the tryptase stays detectable longer, so it is more useful clinically, and it can get asked on exams. Another thing is leukotrienes. Leukotrienes are powerful mediators of bronchoconstriction and inflammation, which is why they matter in allergic airway disease. So if we see hives, wheezing, low blood pressure, we should think about type 1 hypersensitivity reaction. IgE and mast cells will do immediate degranulation and release histamines and leukotrienes. Okay, now we talk about late phase, which happens in hours. So this late phase is a separate concept from the immediate histamine burst. It happens in hours. Chemokines attract inflammatory cells, example eosinophils, and other mediators from mast cells cause inflammation and tissue damage. Why chemokines matter? Chemokines are recruitment signals. They bring more immune cells to the area, turning a quick reaction into sustained inflammation. And because in allergic disease, eosinophils are a major effector cells. They release inflammatory mediators and toxic granule proteins that contribute to ongoing symptoms and injury. So why this phase causes inflammation and tissue damage? Because once inflammatory cells arrive and remain activated, the reaction becomes prolonged, which can lead to persistent airway irritation and damage. Clinically, this helps explain why allergic diseases can have persistent inflammation, tissue injury, and ongoing bronchial hyperreactivity, especially in asthma. So what are the tests for type 1 hypersensitivity? They are either skin test or blood test, which is ELISA for allergen-specific IgE. How skin test works? Because mast cells in the skin can already be pre-sensitized with allergen-specific IgE, so add allergen locally and you trigger antigen cross-linking, mast cell degranulation, histamine release, and you get the classic wheal and flare. Now, why blood test ELISA works? It detects allergen-specific IgE in blood. It's useful when skin testing is risky or not practical. So the examples of type 1 hypersensitivity reaction is anaphylaxis, example food, drug, or bee sting allergies. So why anaphylaxis can be life-threatening? Because mediator release affects the whole body. There is systemic vasodilatation and capillary leak that leads to shock, hypotension. Airway swelling and bronchoconstriction leads to respiratory compromise. Okay, and why epinephrine is first line? Because it treats the dangerous physiology immediately. Alpha-1 action causes vasoconstriction that raises blood pressure and reduces edema. Beta-1 action supports cardiac output, and beta-2 action causes bronchodilation and decreases mediator release from mast cells. Antihistamines can be added. They can improve symptoms, and steroids can help with later inflammation, but they do not fix airway and blood pressure fast enough in true anaphylaxis like epinephrine. Okay, why allergic asthma fits type 1 hypersensitivity? Because it is driven by immediate mediator release, including leukotrienes causing bronchoconstriction. There is late phase, which includes inflammation, often involving eosinophils, contributing to persistent hyperreactivity. So to summarize type 1 hypersensitivity, so it occurs minutes after exposure. Antigen cross-links preformed IgE on presensitized mast cells, causing immediate degranulation and histamine release, tryptase release, and leukotrienes release. And then there is late phase, which occurs hours later. Chemokines attract inflammatory cells, example eosinophils, and other mediators from mast cells. They all together cause inflammation and tissue damage. So supportive lab marker for anaphylaxis is tryptase, because it's a marker of mast cell activation and persists longer than histamine. And the best immediate treatment for anaphylaxis is epinephrine, because it rapidly stabilizes blood pressure and airway and reduces ongoing mediator effects. In addition, it is good to remember that interleukin 4 and interleukin 13 drives class switching of B cells to IgE, and interleukin 5 activates and recruits eosinophils. And what are the cells and receptors involved in type 1 hypersensitivity? So the cells are mast cells, basophils. Mast cells and basophils are the key cells because they are packed with granules like histamine and tryptase, ready to release fast. On the first exposure to an allergen, the body makes allergen-specific IgE. So that IgE binds tightly to a high affinity receptor on these cells called Fc epsilon R1, which is a high affinity Fc receptor for IgE. The mediators that these cells release are histamine, leukotrienes such as leukotriene C4, T4, E4, and tryptase. Again, core disease examples are anaphylaxis, allergic rhinitis, urticaria and angioedema, allergic asthma, atopic dermatitis, or eczema. So skin testing pattern would be wheal and flare pattern to confirm IgE mediated immediate reaction. And remember, type 1 hypersensitivity is IgE, and type 1 has immediate phase, which happens within minutes, and late phase, which happens in hours, compared to type 4, which is delayed and it is T-cell mediated reaction. Okay, so that's all for type 1 hypersensitivity. Thank you and have a very good day. Bye bye.